Hello friends, today we are going to discuss the interpretation of the antibiogram as a part of our ID course. And as we all know that cultures are slowly becoming a part of our culture for the diagnosis of infections, and we are routinely sending cultures from various specimens for the diagnosis and management of infections. Um, when we talk about lab diagnosis, which in fact are the basic tenets for antimicrobial stewardship, infection control, so to identify the microorganisms, there are basically 5 approaches which can be adopted, and these include microscopy, culture and sensitivity, serology, antigen detection, and the molecular assays. And today we are going to focus on the interpretation of the culture and sensitivity predominantly. So, how do we routinely perform antimicrobial susceptibility? So, the routine methods include the diffusion methods, which includes dropping of the antibiotic impregnated disc on the culture media, which contains the culture of the bacteria, and the maximum concentration of the antibiotic is at the center, and then it decreases at the end of the disc. And the susceptibility is assessed by measuring the zone diameter and then comparing it with the standard, which is identified based on the various clinical studies and trials. The second way of estimating the susceptibility is by assessing the MIC. MIC stands for the minimum inhibitory concentration of the antibiotic, which inhibits the growth of the microorganism. And this can be assessed by the broth microdilution method, where serial antibiotic concentrations are added to a particular concentration of the microorganism, and the concentration which inhibits the growth of the organism, which is estimated by clearing of the zone, is the minimum inhibitory concentration. And this MIC can also be assessed by looking at the E strip. It's the lower end of the zone of the zone of clearance, which actually tell us the MIC of the antibiotic for that particular bacteria. Now, more and more, we now have automated microdilution methods which actually tell us this whether the particular isolate is sensitive or resistant to the antibiotics. And there are also certain mechanism of resistance which detect particular specific mechanisms, like we have the expert CARBAR, which detects OXA48 NDM KPC, and we can also have certain genotypic detection methods for detection of the MEK gene. So these are the various methods by which we can actually detect the resistance, and this will help us in choosing our antibiotic. Now, in today's discussion, I'm going to discuss whether the culture report which we receive is actually reliable or not. Then we will discuss regarding the clinical interpretation of the cultures. We'll also discuss regarding the susceptibility, the mechanism of resistance, as well as the MIC. We'll discuss regarding how we should choose our empirical antibiotic therapy and definitive antibiotic therapy based on the interpretation of the antibiogram. And of course, we'll discuss the impact of the antibiogram on the antimicrobial stewardship. So let's take up the first one, which is whether the culture report which we have received is reliable or not. So this is a patient, this is a 65-year-old lady who is presenting with dysuria as well as frequency. And this is the culture report. So you actually see a urine culture which is growing E. coli with a significant colony count of 10 to the power of 5 bacteria per ml. And this is the susceptibility report. Here we see there are certain antibiotics which are reported as 4 plus. There are certain antibiotics reported as plus. So it's basically reported as plus plus. And with this particular report, which antibiotic will you choose? So ciprofloxacin reported as 4 plus, amikacin again 4 plus, cefixime which is reported as 2 plus, or none of the above. So the right answer is actually none of the above. Why? This is because this is not the way the antibiotic or the antibiogram should be reported. If Dr. Camila Rodriguez actually, says that if you see a report like this, we need to change our microbiology lab. So as we all know that now, the reporting has to be either sensitive, intermediate, or resistant, and not as plus plus. So this is a wrong report. And when we say that, that a bug is reported as sensitive, intermediate, or resistant, what does it actually means? It means when it is reported as sensitive, that the particular isolate, it can be treated with the normal doses of the antibiotic, provided the antibiotic is achieving an adequate concentration at the site of infection. It means that the chances of success are close to 94 to 98%. Now, when we talk about intermediate, it's basically like, the here, um, uh, the chances of achieving a success is close to 60 to 70, 60 to 90%, and it depends upon the source control, as well as the concentration of antibiotic which is achieved at the site of infection. And sometimes, especially for example for the urinary infections, beta lactam and quinolones, even if they are intermediate, can be effective because they achieve higher concentrations into the urine. When a particular antibiotic is reported as resistant, in that case it means that the success rate is less than 16%. The chances of cure are very less. So the take home message from the first, from this particular case, is that it's very important to identify the reliable reports. You can, like, the a lot of times the report is available, but a careful interpretation of the report is extremely important. Now let's go on to the first one, the clinical interpretation of the culture reports. Uh, so let's begin with, we'll do it with the help of this particular case. Okay, so this is a patient who had actually presented. This is a young boy who was in the ICU for a long time. Now he was shifted to the wards, and here he had a tracheostomy. There was also a peripheral cannula which was in situ, and he was on beta lactams, and he had a urinary catheter. Now when he was shifted to the wards, he started having fever, and that's when the cultures were sent. So the blood culture which was sent grew the Staphylococcus hemolyticus. It was a single blood culture which was positive, and the urine culture which grew which grew Klebsiella pneumoniae, which was carbapenem resistant. So and to this, based on this culture reports, he was started on tigecycline and colistin for the persistent fever. And that's when an infectious diseases reference was sought. So what is the next best step in the management of this patient? Continue with tigecycline and colistin, shift to vancomycin and colistin with imipenem, that is the combination therapy for the carbapenem resistant Klebsiella pneumoniae. Repeat the cultures from both the sides again, or none of the above. So here again, I think, it's very important to go back and assess whether whatever the culture is available to us, whether it's really clinically significant or not, whether it's true infection or is it a colonization. And so there are various factors which can be used for differentiating between the colonization and infection. So as we all know, like, we actually live in a sea of microbes, and it's almost the microbes can colonize any body surface and contaminate any clinical specimen. So if a culture is positive, it's important to differentiate whether it's actually infection or colonization. And the various factors which will help us in differentiating include whether what is the specimen, whether it's a sterile specimen or it's a non-sterile site. For example, the sterile specimens would be blood, CSF, pleural fluid, pericardial fluid, ascitic fluid, whereas the non-sterile sites would include a urinary catheter, a throat swab. These are the non-sterile sites. organism. So blood is a sterile site. But if the blood culture is growing Staphylococcus hemolyticus, which is a skin colonizer, then then a single blood culture is likely to be a contaminant rather than a true infection. On the contrary, if suppose the blood culture is growing Staphylococcus aureus, so aureus is a red sign, it's a red herring, and it will be even a single blood culture positive with Staph aureus is significant. A single blood culture positive with Candida will be significant. It depends upon the clinical status of the patient, whether the patient is hemodynamically stable, unstable, running fever. This will again help us in identifying whether it's a true infection or colonization. The immune status of the individual, for example, a urinary culture positive for Candida in a neutropenic patient will be considered as significant rather than a colonization. On the contrary, if it is a immunocompetent patient who is who is in the ward or even in the ICU, clinically stable, but has a urine culture positive for Candida, then it is likely to be a colonization. In the presence of processes, for example, a blood culture which is growing Staphylococcus hemolyticus or cons in the presence of a central line will become a will be there are higher chances of it being a infection rather than a colonization, or in the presence of a prosthesis. Now compatibility, again, histopathological compatibility is equally important because there can be invasion, there it must show invasion necrosis. Again, a compatible radiology will be useful in identifying, for example, a patient who is in the ICU has multiple nodular infiltrates and then subsequently has a aspergillus which is positive from the ET secretion, can also be a will help in suggesting that the aspergillus isolated is not a colonization but a true infection. So everything is important, compatible histopathology as well as radiology. All this will actually help us in differentiating colonization from infection. Now, going back to our case, here the blood culture is a sterile site. However, this is a single blood culture which is positive for Staphylococcus hemolyticus. Remember, we have to always look beyond Staphylococcus, see whether it's aureus or it's not. So hemolyticus, epidermidis, etc. These are our coagulase negative Staphylococcus, which usually colonize our skin, and a single blood culture is likely to be a contamination. And in fact, time to positive can also be used for differentiating colonization from infection if the time to positivity is less than 16 hours, and if more than two blood cultures are positive, then it will go towards clinically significant or clinically infective. Whereas if it's a single blood culture, then it's very likely to be a contaminant. Now, now in this particular, coming to the interpretation of the urine culture, so here as we can see, this urine culture urine is a non-sterile site, and this patient, if we looked back, this patient actually had a catheter in situ. So this was a catheter associated, the sample was taken from the catheter, and as we all know that there is a 5% incidence of bacteriuria per day of catheterization. So if a patient is catheterized for 30 days, almost all the patients, if the urine is taken from the catheter, will show bacteriuria. So this plus there was the urine routine actually has no role in interpretation or whether the patient has a UTI or not in a catheterized patient. Urine routine in a catheterized patient will show some pyuria and is not useful to differentiate it from UTI or not. Again, what is important is to look into the creatinine. If the creatinine is not high, urine output is normal, or there is a decreased urine output, and plus imaging. If there is no evidence of pyelonephritis, that will again go towards colonization rather than infection. So in this particular patient, the patient was clinically very stable. The blood culture was growing corns, which is likely contaminant. The urine culture was obtained from a catheterized sample. Hence, the possibility of drug fever was considered, and the antibiotics, both colistin as well as tigecycline, were actually stopped. And slowly, there was resolution of fever. So, drug fever is um, one of the underdiagnosed